Dr. John Polio is Associate Clinical Professor of Medicine, Division of Gastroenterology, University of Connecticut Health Center, attending gastroenterologist, St. Francis Hospital, and co-medical director of the liver transplantation service at the Hartford Hospital. He's here to talk about the abdominal examination. Welcome, Dr. Polio.
Thank you very much, Dr. Steiner. It's a pleasure to be here.
I wonder if you can help us know if the 15-degree angle of the abdomen or the purely flat abdomen is better for physical examination.
I don't really know the answer to that, to be honest. My preference is to keep the patient fully flat because I think that decreases any tenseness on the abdominal rectus muscles and enhances the exam. But I don't think that that area has been studied, at least not to my knowledge. And in my personal experience, it doesn't seem to make a huge difference, but I usually keep the patient as flat as I can during the exam.
And do you have any tips for helping to relax the abdominal musculature in the patient who seems unduly tense or where you're convinced there's something hiding under the abdominal wall waiting for your fingers to find?
Well, there's a few techniques that I think you can to use. One is distractibility, and there's a few ways to do that, but I find one of the best ways is just talking to the patient often about a topic that's unrelated to your specific exam. You're taking their mind off what you're doing, yet still being cognizant of what the patient's reactions are to your palpation. The second technique that helps is lifting the knees up. So the patient is in the supine position, and you flex at the hip with the knees off the bed, and that will decrease the abdominal muscular tenseness or tone and may enhance palpation.
On the rectal exam, one of the frustrations of all of us in practice is that it seems the younger the examiner, the less likelihood that they will do a rectal examination. And yet, when we read the write-ups by some house staff, the rectal examination description is confined to stating whether the stool tested positive or negative for fecal occult blood. Is there any other value to rectal examination?
Well, your point is well taken. I think the rectal exam is an important and often overlooked portion of the examination. And physicians don't do it for any one of a variety of reasons, including their own uncomfortableness with the exam and their perceived uncomfortableness of the patient, which usually is not the case. Patients will often be very cooperative with an exam if it's done in a respectful and careful manner. So I believe that the rectal exam is an integral part of the abdominal exam and should be used routinely.
Thank you so much. I'm looking forward to watching your abdominal exam.
Well, I'm looking forward to showing it to you. Thank you. This is our patient today, Mr. Taylor, who's consented to help me demonstrate to you the examination of the abdomen. Good morning.
Good morning.
Mr. Taylor, we're here today to demonstrate the physical examination of the abdomen. And there's a couple of important points that I'm going to make right off. And the first is that there should always be hand washing before and after a physical examination. And we're going to assume that that's already been done at this time. The second has to do with the patient. And it's important for me to make sure that you're in a comfortable position before we do the exam. Positioning of the patient in the abdominal exam is very important because that allows the patient to be cooperative with the exam and to help the examiner demonstrate the points that he or she needs to identify. The first thing is I'm going to have the head of your bed down a little bit. I'm going to adjust that for you. And you let me know if you're comfortable right here.
Oh, that's fine.
Okay. It's important to inquire about the patient's comfort. Some patients may have a mild kyphosis of the spine. They may require a pillow for support. Some patients may be short of breath, and you may not be able to lie them in the full supine position. You may have to make adjustments for that during the examination. The second part of the preparation is for me to drape you appropriately to give you privacy during the exam. And there should be a lower drape placed right below the pubis, and the upper drape can be placed right below the breasts. And this allows for adequate visualization for the examiner and provides some privacy for the patient. It's very helpful to look at the patient's abdomen from a set position. I choose to look at the abdomen from the foot of the bed. And it's also helpful to identify a light source to try to cast shadow on the abdomen, and that can point out different changes in contour or texture of the abdominal wall. What am I looking for? Well, I'm looking for changes in contour, abdominal masses or bulges, abdominal scars on the abdomen, change in the normal venous pattern of the abdomen, any change in the texture of the abdominal wall. Now, in Mr. Taylor's case, if I look from this portion of the bed, the abdominal wall seems relatively symmetric. He does have some scars. One that's clearly apparent is right here. It's a right subcostal scar, and that would be consistent with prior cholecystectomy. The abdominal quadrants, right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. Now, there's other ways to divide the abdomen, and the other typical way is into a number of different geographic areas. One is the epigastrium, which would be centered here, the right and the left hypochondrium, the umbilical region, which is in the region of the umbilicus up and down, and then the lower quadrants here. Well, we've inspected your abdomen, and we've seen that you've had scars from prior surgical procedures. But otherwise, your abdomen is relatively symmetric. I'm not seeing any distortion of the abdomen. I'm not seeing any unusual masses or bulges that would call my attention later as part of the auscultatory or palpation part of the examination. Okay, well, I'm just going to examine your abdomen with my stethoscope. Okay. Now I'm listening in all the different quadrants of the abdomen, the quadrants that we just reviewed, and I'm listening for an adequate amount of time to ensure me that I'm getting a good representation of what the bowel sounds are. Sometimes you may need to listen for a much longer period of time, especially in a situation where you're suspecting an ileus. Next, I'm going to listen for bruits. In regions looking for renal artery bruits. And over the femoral arteries. And I don't appreciate any bruits in this particular case. Now, there are a couple of other inspection portions of the examination that I'm going to point out very briefly now. One is around the umbilicus. You can often see hemorrhagic changes there, a so-called Cullen sign, and also in the flanks, a so-called Gray-Turner sign. Now, on palpation, there's a couple of ways to palpate, but I find that this portion of the finger is the most sensitive. And I think if you start with gentle, light palpation first, and then progress to deeper palpation, you'll be more comfortable. And if you're more comfortable, I'm going to have a better exam. So again, I usually try to focus in an area that is not the focus of the patient's complaint, and I just gradually palpate across your abdomen. If you have any discomfort, let me know. No. It's also helpful to talk to the patient during the exam, often about something that's unrelated to the examination. That distracts the patient and again enhances your ability to get a more appropriate exam. Mr. Taylor, do you work?
I do, yeah.
What do you do for work?
I'm retired. I work part-time.
Where is that?
I'm a massage therapist.
Oh. How am I doing?
You're doing fine. You're doing fine.
Maybe we should switch positions. Well, I've gently palpated the abdomen, and I'm not feeling anything of concern. But again, this is relatively light, superficial palpation. And I'm going to now press a little deeper. Now, when I press deeper, I use my opposite hand to press down on my examining hand. So again, I'm palpating lightly, but now I'm going to press a little deeper. Okay? And I move my hand back and forth, trying to mobilize the organs underneath the abdominal musculature. If I cause you any discomfort, just let me know.
Okay.
What am I focusing on? I'm focusing on the presence of any masses, any asymmetry in the abdomen. I'm looking for signs of tenderness or vocalization of tenderness from you.
No, nothing.
I'm going to palpate the femoral artery. I'm going to palpate for any evidence of lymphadenopathy or for hernia. There's some specific maneuvers for hernias that we can go over later if we need to. I'm going to palpate the umbilicus. Now, there's often tenderness over the aorta. It's a non-specific finding. It's very typical. Now, as part of the